Hi, I'd like to welcome everyone. I think we're a little bit past our time here, so we need to get going. Okay, so here we are today. It is November 13th, and we are back together again. We have this meeting, and then next month, and then we will be starting the next session by the time we get to January. So we have 2 months to get some work done and finish up our strategic plan and make some recommendations to the legislature. Just a tiny bit of work. Today, we're going to focus on data. So I just want to say thank you for being here. Thank you for being online. And thank you all for your commitment. And I will turn it over to my co-chair, Representative Exum.
Good afternoon. It's so good to see you this afternoon. Just thank you for being here. And yeah, let's get started. Claudio?
Good afternoon, everyone. Really quick, since this is the first time we're gathering since an election and there was hard-fought elections on all sides, I just want to extend my appreciation for everyone who stood for election and brought these issues to bear in living rooms and dining rooms across the state. I think it's one of the greatest things to sort of have democracy be brought into the community and through the vote. So regardless of winning or losing, I just want to echo my appreciation for everyone who was part of that process and certainly appreciate working with everyone here. Thank you.
Thank you, everybody. Good afternoon. My name is Erica Nowakowski. I'm the Executive Director for the Tau Youth Justice Institute, and very excited to get this meeting started. As a couple of housekeepings that we need to do. First is the acceptance of the October meeting minutes. Could we get a call for the acceptance of the October meeting minutes?
So moved.
Is there, yep. Is there a second?
Second.
Second. Okay, thank you. Any revisions, changes to the October meeting minutes? Okay, seeing none. All in favor? All right. Any abstentions? No? Okay. Thank you. Couple things I'd like to bring to your attention today, just really quick. I'll take a couple minutes. You officially have a new TCB administrative team, and want to take the time to have them introduce themselves. As you may recall, we had Ash with us for some time, and she left us in May, which was very sad because she was amazing. And I know she's still doing great work. And we also have Israeli, who is actually not leaving TYJI, Tau Youth Justice Institute, but just moving up to a different department in our institute. So very proud of the work that she has done this past year with you all. And with that, we have spent several months throughout the summer since May. We've been engaged in some outreach and really doing some recruiting. And we have 3 staff that will be joining your team as the administrators for this work. And I'm going to give the floor real quick to Emily, and then to Jackie, and then to Stacy.
Hello, everyone. It's nice to meet you all. My name is Emily Bombach. I'm the Senior Project Manager at TCB. Prior to coming here, I worked at a behavioral health hospital as a quality and patient safety specialist. And prior to that, I worked at Health Equity Solutions in Connecticut as a policy and advocacy specialist. I'm very passionate about bridging equity and intersecting it into policy, and I'm happy to work with you all.
Stacy?
Hello. Can I be heard? I want to make sure. Okay. Hi, my name is Stacy Alea. I am the TCB project coordinator. In regards to my background, I have been a case manager for about 5 years. I've worked with different agencies from the Bethel Center out in Milford to JCCA and Housing Works in New York City. I've also worked with 211, Safe Connect, as well as other nonprofit organizations. My passion in regards to being the safety of children. I'm heavily focused on children's behavioral health and making sure that a lot of low-income families are receiving the help that they need.
Yeah. Jackie?
Hi everyone, my name is Jacqueline Marks. I'm a project coordinator for TCB. I'm very excited to be here and happy to meet all of you. I have work experience as a litigation paralegal and mental health services specialist. I hope to one day be an attorney I'm very passionate about policy and law and working with youth. I'm excited to be here. Thank you.
Thank you. And so, for purposes moving forward, there's a couple things that you will see. We are going to, as Israeli is transitioning out, we are going to clean house with the Outlook invites. So there will be several cancellations that you will be receiving if you had something already on hold on your Outlook. And we will be transitioning that invitation from Emily. So you will then receive invitation for Outlook, which will come from Emily. So just wanted to let you know that that will be taking place in the next couple of weeks to make that transition happen. Okay, and then and feel free, please, to send any of your questions or feedback still to myself and or to Emily. With that being said, we will move over to the specific items on the agenda. As Senator Marr mentioned, today's meeting is focused on data. And what we wanted to do, and what I hope that we can do as a committee moving forward, and especially into maybe the fall of 2025, is that we spend some time doing pulse checks or temperature checks on our data. What does our data look like in our children's behavioral health? Where are our kids? Not just the basic utilization numbers, but also the outcomes. Where are they in the system? What type of services are they receiving? What kind of outcomes are we seeing? Where are the gaps in the data as well? And where are the barriers to the data? And so really asking ourselves those questions so that we can be better informed in the sense of what Senator Marr mentioned of feeling that we are equipped to be prepared for the legislative session, whether it is as a legislator, you have an understanding of the data of a children's behavioral health, or you as an advocate to advocate for specific recommendations and be equipped with that information. So the next several months, we're going to be working together and trying to establish what does a data platform look like, or a pulse state on children's behavioral health in Connecticut in regards to data. And so with that, for today's focus, we're only going to focus, as you all know, children's behavioral health is a significant array of services and path. And so today we're really going to focus on the emergency services aspect of that continuum of care. And so we have several presenters. The first part of the presentation will be from Kelly Randall from Child Health Development Institute, Amy Samela from The Village, and Erin Saylor from Child and Family Agency. This will focus on emergency mobile services as well as the urgent crisis care centers. So I'm going to give the floor now to Kelly.
All right, thank you. So good afternoon. I am so pleased to be here today to share some of the data and updates on mobile crisis as well as the urgent crisis centers. So my name is Kelly Randall. I'm the Associate Vice President of Quality Improvement at the Child Health and Development Institute, and I'm going to be starting us off and really taking a look at the mobile crisis program. I'm then going to be passing things over to my partners. So Amy Samela, Vice President of Residential Programs at the Village for Families and Children, and Erin Saylor, Chief Operating Officer at Child and Family Agency. So they will be continuing the presentation, picking up on this data thread, really spotlighting some of the numbers that we have from the UCCs and discussing some additional updates and anticipated challenges with the UCCs. So you can advance to the next slide. And so at the top, I just wanted to acknowledge DCF, who does provide funding and oversight of mobile crisis and the UCCs, as well as funding the Performance Improvement Center for both services at CHDI. So the Performance Improvement Center really provides an independent entity to collect and report the data, and then use that data to inform training and practice and do site visits with the providers. So having the center is really why we're able to provide this data to you today. And it's also how we know that the data is consistently being used by the providers to further their quality improvement activities. All right, so before kind of diving into the specifics of mobile crisis and the UCCs, I did want to just briefly touch on Connecticut's overall crisis continuum for children. So SAMHSA has established national best practices for crisis services generally, as well as specific guidelines for children and families. Both really focus on these three key elements: someone to contact, so a centralized call center, 211-988, someone to respond like we have with our mobile crisis teams, and a safe place to be. And there really is a range of options where a safe place to be could be based on the child's needs. But for today, we're really focusing in this presentation on the UCCs and how they're meeting that need. So these pieces really operate as a system, with each phase of the model being very dependent on the other ones. So if we're going to be providing robust and high quality services for children that are in crisis, they really need to all three be there and supported and connected to one another. Another thing that's important to keep in mind looking at this is that is where it sits within the entire system. So we do have that darker purple box at the bottom, which really highlights that these crisis services are embedded within a broader community-based system of supports. So when we are seeing children and families accessing these services or emergency departments for behavioral health reasons, it's often a symptom of problems kind of further upstream. So when, the more preventative, less intensive services are for whatever reason less available or harder to access, you're going to see some of the effects of that in the crisis system in the service array. Also, once the crisis is stabilized, children and families are being connected back into that system with those community-based supports. So we are going to zoom in really carefully on mobile and UCCs, but just kind of recognizing that it is only one piece of this broader system. And so going into some of the details on mobile crisis, the one thing I did want to say right at the top is that Connecticut really is a national leader in this area, and we get a lot of recognition for our youth mobile crisis program. So like our data, the practices, the outcomes have really helped inform the national conversation as other states are trying to figure out how to deliver mobile services to children in their communities. And I think one of the reasons is because of the goals and values and principles that our program has. Go on to the next slide. So the overall goal is to provide consistent, high quality service for children and families in Connecticut. And so the first is really that the service is highly mobile, that it operates with a just go approach. So if someone is picking up the phone and asking for help and they want somebody to come out, then somebody is going to come out face to face in person. So there isn't a screening out. It's really all guided by the family's choice or the caller's choice. The next is to be responsive. So the standard is to arrive within 45 minutes and really kind of adhering to this principle of meeting a sense of urgency with urgency. If someone feels like it is a crisis, mobile crisis is going to respond accordingly. Mobile does currently operate 24/7, 365, and there's a goal to reach everyone that could benefit from the services. So there's activities around community awareness, as well as building up partnerships with schools, emergency departments, police, foster families. And ultimately, the overall goal is to help avoid the use of restrictive services whenever possible. So if a child can be safely treated in their home or community, that is what we want to do, and avoid EDs and inpatient and arrests and all those options if they can be avoided. The next slide just has a very brief overview. We're going to be doing some spotlights of the data, but I just did want to draw our attention that we did just publish the fiscal year 24 annual report for mobile crisis, which does have a lot of data broken out in many different ways. So that report, as well as all of the work that we do, is really kind of framed around kind of the picture that you see on the right-hand side, and that the things that we're looking at are access. So who is using the services? Quality, are the activities that are being done in the service those that we know are associated with the better outcomes? And then outcomes, what are the indicators that children and families are better off? And kind of cutting across all three of these is equity. So we don't want things to just look better overall. We want to make sure that things look better for everyone that's using the service. So we're continually breaking down the data, looking at things by race and ethnicity, by region, by gender, by age, and then rural versus urban, which we have an example of. On the next slide, in fiscal year 24, we had 11,346 episodes across 8,428 unique children. In terms of who is calling mobile crisis, the top referrer was schools, very closely followed by self and family referral. So pretty much almost even there, 42 and 41%. And then just one kind of simple metric to think about who's accessing mobile crisis is comparing it to the Connecticut child population, which you'll see there are more Black youth and Hispanic youth served in mobile crisis than overall. So that isn't the only relevant comparison. If we're really trying to divert from inpatient, from EDs, from arrest, those are additional populations of focus. But that's kind of one simple statewide comparison to give a general idea. The next is the map that shows in fiscal year 24 the use of mobile crisis. So this is calculated as the number of children per 1,000 in each town. And you can see that pretty much almost every single town had at least one mobile crisis episode responded to during the fiscal year. The darker blue represents like a higher proportional rate, and then the lighter blue is less. And those orange kind of yellow dots represent where we have the mobile crisis provider locations. So it really is a statewide service. In terms of the reasons why mobile crisis is being used, consistently the top presenting problem has been harm and risk of harm to self. That's 29%, and it's also pretty consistent that disruptive behavior is closely behind at around 0.25%. Sometimes we do see that risk of harm to self go up a little bit closer into like the low 30s, but kind of those being the top two and the relative proportions is pretty consistent across mobile crisis. And the pattern is also pretty similar in the UCCs. Other reasons you can see: depression, anxiety, harm, risk of harm to others, school problems, family conflict. On the next slide is really kind of taking a very quick look at our quality metrics. So I think having these established mobility and response time metrics and the benchmarks is one of the things that really has set Connecticut's program apart. So mobility rate is exactly what it sounds like. How often mobile crisis clinicians are actually going out and meeting the child and family. And this is always going to be driven by what the family wants. So sometimes, there can be an instance where they're not asking for a mobile response, and mobile's not going to go out if they are not requested to. But the 94.4% is when someone is asking for someone to come out. That's the percent of the time that someone is actually dispatched and getting in a car and responding in person. Most often, when they want a response, they want it immediately. And so for those immediate responses, the expectations that they get there in under 45 minutes. That's the benchmark that we've set. And that 80% of the time, they should be getting there in under 45 minutes when it's asked to be an immediate response. And we exceeded that in the year with 86.6%. So one thing I think is really important to note that these are quite ambitious benchmarks. So when there are other states that even do have any sort of statewide or even regionalized mobile crisis program, I think like an hour is very common, and sometimes two. So we do have the benefit of being a small state and having that statewide coverage, but that 45 minutes is probably the highest that we have. And in terms of kind of what is happening to the other ones, like who's not getting 45 minutes, we do know that moving up, 95.4% are getting a response in under 60 minutes, and then it's 98.4 in under 90 minutes. So we're still aiming for that 45, but even when you're going beyond that, the vast majority of children and families are getting a very timely response. The next is a requested kind of breakout of urban versus rural response times that was requested for this presentation. And so we used the Connecticut Office of Rural Health designations of rural towns and then compared them to all the other ones. So you have urban, which is everyone that was not designated as rural, versus the identified rural towns. So off the bat, there really are more episodes within the urban and suburban cities and towns compared to rural. But after that, the median response times are quite similar. So we have like a 2-minute difference there. In terms of meeting the benchmark, so expecting 80%, it is higher in the urban with 87.1, but still exceeding the benchmark with 83.3%, even in those towns that are a little bit further out from the providers. And then keeping in mind kind of those numbers I had just shared with, 95% getting a response in under an hour, regardless of where they are, and it being closer to 98 minutes or 98% for 90 minutes. And then one other kind of really relevant piece that helps us segue into the next one is how mobile crisis and UCCs are having referrals to and from one another, which is something that I think we're still learning about, both starting to get some of the data and also figuring out when are the circumstances and the right times for, to direct families to one service or the other. this slide really does have the data from the UCC side because they had those data elements earlier than mobile crisis. So now it is being collected on the mobile crisis side as well in terms of how often they're getting referrals from UCC and referring children and families to the UCCs. So in the 3 quarters that we had, there was 35 from mobile crisis to UCCs, and then UCCs referring to mobile crisis was 52 times. But I think that those numbers don't really capture all of the partnering that happens between mobile crisis and UCCs. And I think there's a lot of coordination on the ground as we're helping to figure out how these two services work together. And so for that, I'm kind of going to hand it over to Erin and to Amy to talk about that and then continue the thread with the UCC data.
All right, everybody. Hi, I'm Amy, and I'm joined here obviously by Erin. So we're here representing the 3 community UCCs. I know there are 4 urgent crisis centers here in Connecticut. We we talk about them as community providers, meaning Child and Family Agency, which is Erin, myself from the Village, as well as Kristen, who is not with us from Wellmore. And then obviously we have Yale, but we really look at them differently because at this point in time, we do operate a little bit differently. So when we talk, we're talking really about the community UCCs. So thank you, Kelly. As Kelly talked about, we do have a really good partnership. I can first talk about our partnership with Mobile Crisis, and then we'll go into some more of the data and what we're doing with the UCCs. But I think first, anytime we're given the opportunity to showcase and to talk about the UCCs, we're going to jump on it. I think overall, we feel like we, not only from our partnership perspective, but also in really helping with the crisis continuum, we feel like are starting to make a dent, and you'll see that through our data and through our utilization. So before I jump right into there, but just to further emphasize the partnership that we have with Mobile Crisis, obviously you can see from the numbers, but anytime you insert a new level of care into something bigger, you have to make sure that you have relationships with the people with the higher level of care above you, as well as the lower level of care below you. And I think that that's what the UCCs do very well. And I think Mobile Crisis is an indication of that. And then on the opposite of the higher level of care, we obviously have partnerships with all of the emergency departments and then inpatients as well. So I think that that's something that we are proud of. But before we really get started, we wanted to showcase an urgent crisis center. And I think that that also is an indication of the partnership. So we included a video, and this is a video to highlight a parent's experience if they were to walk into one of our UCCs. And just to say before we start the video, if you were to walk into the Village's UCC or Erin's UCC, while you might have obviously different faces, the feel is going to be very similar. And that was done intentionally from the workflow perspective, in addition to the environment of care. We wanted to showcase it, obviously a different experience than an emergency room, but very similar wherever you go in the state. So with that, we can, I guess, quickly show the video. I think it's about 3 minutes.
We're gonna have the same impact without volume, but.
Okay, they're calling CTF.
Okay.
Yeah. You want to have a different slide while we do it?
Sure,
Yeah.
I don't know, can you hear me from that mic or should I turn this one on too? One of the reasons that we did this video, just to speak a little bit to the marketing, was it's being an inaugural program. And I think in our experience, anytime we've started any new program and implementation, it takes really 3 years for the community to understand what it is and to really have it embedded in the community. And I think for something like this, we need the system to really understand what it is. We need DCF partnership, and we need emergency medicine. Because we need emergencies, vehicles to be willing to come, and the police to partner with us. So we need a full system, and we need parents to trust that this service is a place that they will care for their children in crisis. We also ask more of parents than an emergency department does when their kids are in crisis. We really see it as a family intervention, and I think we all say a kid in crisis is a family in crisis, so we really need to wrap ourselves around the entire family. And because we're a behavioral health intervention and a multidisciplinary intervention, that's our primary focus and purpose, we really embrace the whole family. And as a result, we ask the whole family to be engaged in the service the whole time. So there isn't the ability to disengage and multitask when you're there. You really are an active participant, which I think feels different. And sometimes when you're a really exhausted parent that has been through the system for a really long time, sometimes the emergency room feels not bad as respite. So, you know, we really have to help families understand that while the initial process of getting in and your active engagement might feel more exhausting on the outset, the end goal is going to actually be more relief. So it's taking a lot of education. As we're looking at this, we're really having to, I like to say like Big Hero 6. I love that movie. I have kids. So, and I love the thought of like turning yourself upside down and really looking at something from a different angle to look at how do we do this differently? And that means we have to market differently. We can't just do our old playbook because that's not going to work. This is new. This is different. So we've partnered with a videographer in the community that's embedded in New London, that knows the community differently. And he's an influencer, and he's brought in actors that are part of the community. And he's doing a series of, and DCF has given us permission to do this video and a series of videos so that we can market and help the community understand, and parents and parents and referral sources understand what this program is in a different way, so that we can increase utilization and really help people understand how we can help them. Do you want to add anything?
No, I wonder, I mean, I don't know if this is going to work. So I wonder if we should just start with the
Yeah.
slides and the data.
So one of the things that I'd like to speak to in terms of volume is that in behavioral health, and I'm sure you all have heard this many, many times across, but there's trends in children's behavioral health across the board. We see increases when school starts and the stress level goes up. We see decreases during the holidays, and then we see increases. March is always January, February, March is always a huge spike. And then it dips again in the summer. And you can see those utilizations changes again in volume. But you can also see that we're continuously trending up. When you look at volume across provider, it's the same trend lines across. The Village is obviously the largest provider in the city. We're more rural at Child and Family Agency and suburban and spread out further. So our numbers are a little bit lower, but you can see the same trend line, and you can see them trending in the different patterns that we see across all of our programming, outpatient, in-home. I think the hospitals, we speak with our Yale partners, they see the same trends that we're seeing in terms of utilization that we've seen for years. In terms of the town volume that you're seeing, I think, again, this speaks to marketing. The brick and mortar part of our service and where we're located makes it a little bit more challenging, especially transportation barriers. We don't have great public transportation in Connecticut. So it is challenging for families to get to us, and getting kids in public transportation in crisis can be very challenging. So that's some things that we're trying to look at. We've at our agency have looked at like Uber gift cards to try to help get families there, or they can get there through the ambulance, but then how do we get them back home? So we've looked at Uber cards and those kind of things to help reduce those barriers. And then we're looking at, in our area, which you can see in the southeast corner, where we're really well known, we have more volume. Where we're not as well known, we have less volume. So we're continuing to try to expand our marketing reach. And I think in an ideal world, we'd have more brick and mortar spots so that access would be easier for families.
And to add on to what Erin's talking about, so much of the marketing, right, and getting the word out relies on us. So we do a lot of presentations, we do a lot of grassroots efforts, driving to all of the schools in the area, handing out pamphlets, knocking on doors, knocking on pediatricians' doors to get the word out. And we, in so many of the recent presentations, right, actually all the presentations, just to kind of piggyback on this map, there are so many people. It's pretty much every presentation, but most recently I was doing a NAMI conference. And there were so many audience members that kept looking at the map and saying, why not up here? Why not up here? You know, can we have more? And I think that's really important information that we keep talking about, right? And so my response to all of that is yes, and we definitely have to maximize and continue to push the efforts in what we do have, because we need to prove our worth, right? We need to prove that we are making a dent in helping families and kids in crisis, but obviously with the goal of adding more and meeting the needs of families. So many of our families will say, and they have to bypass local emergency rooms to get to us, and they do. We have, you know, at the village, we had a family that came from all the way from Bridgeport, and I know that that actually is far in the state of Connecticut when you have a person in crisis, right? You have to drive an hour to get to us. And, you know, we're happy to say that that was a positive experience. And then we do all of the outreach and the supports to get them connected in their towns. But we don't have a catchment area. So you can go from one state to Aaron's program or to the village's program, regardless of where you live. And we definitely continue to market that to make sure everybody in the state knows that they can access the UCCs regardless of where they live. Um, to echo and to talk also a little bit about the utilization. So at this point in time, we have almost 1,500 kids and families that we served in the 3 community UCCs. And actually a big number, right? You talk about programs that have only been operating for a little bit over a year when all of the marketing is coming from our voices, right? Not just our voices, but then we utilize, again, where all this referral numbers come from. We need to get to people, right? So what you see here is our most recent referral sources. So schools, obviously the highest, and I think this mirrors some of the stuff that Kelly was talking about with mobile crisis. Schools and self, the families are the highest numbers, and that's not surprising. But what is interesting is if you were to look at the quarter before this, you would have seen schools at 70%, and then, you know, the numbers a little bit lower. And I think while schools will always be probably the highest number, I think the ones getting a little bit increase is showing sort of the efforts of all of the marketing that we're doing. We're getting to the pediatricians, we're getting to all the community providers. You know, I happened to do a presentation this morning, and there was a lot of families on the team as part of the meeting from Favor and other advocacy groups. And so really getting to the families is super, super important. And then word of mouth. You know, there's a lot of families that have come to us that said, you know, we asked them, how did you hear about us? And it's other families, right? Or it's, I went to the ED. This is really cool. I know, Howard, you're here, but we have a relationship with CCMC. And if for kids leaving CCMC, they get our brochure, right? So next time, if you're in crisis, instead of going to CCMC, go to the village's UCC. Those are the relationships that we're really continuing to build so that we get families in the right door so that they don't have to be sitting in the emergency room if they don't need to be seen. The other number that's really important on this screen is the ambulance, arriving by ambulance. So I know that that was a big focus when the UCCs first came to fruition, and there was a lot of barriers, right? We had high hope that we could just flip the switch and ambulances, emergency crew would just start driving up. You know, now that the law changed and the payment structure changed, you know, word is getting out there, but there's still a lot of bumps, right? So we have, I forget the number, but it's like over 100 different EMS providers in the state of Connecticut, right? That's a lot. And just because the directive says you're allowed to use the UCCs doesn't mean they understand it, buy into it, or want to take the risk, right? Because there's an easy way out. They could just go to the emergency room. So we're doing a lot of, again, education. We go out, we go to AMR, we go to Aetna, we go to all of the different service providers, and we educate, and we have sort of a question and answer conversation, and then we do like a quality loop. We had 2 recent ones that were huge misses, with a particular provider. And we wanted to go back and say, what happened? We heard this happen, why? And then we go back and then we talk to dispatch and we talk to the driver and we kind of go power through to correct it for next time. Same with all the other ones. So while the number is low, 30 in a very short period of time is actually showing quite improvement. So we're really, we have high hopes for that. We're also working, I can speak to the village just because it's a really unique partnership that we have with CCMC in particular. So CCMC has some great data where they talk about schools, right? So they gather kids coming into the emergency room. They know what schools, at least the schools that they live near, right? So they might not all go to all those schools, but it's a directory of information for us right now. And so we know currently from the Hartford area, Enfield happens to be the highest number of kids going to CCMC. So now over the next month, we're going to be working with Mobile Crisis, UCC, and CCMC, where we're going to be tackling Enfield School District. They don't know this yet. We haven't made contact with them, so just saying. Where we're going to be going to their leadership and saying, your numbers are high. We, as a threesome, we would like to get into your school district and do a lot of education to talk about who should go where and do a lot of proactive planning. So that's what we're doing going forward to really tackle some of the challenges. I think on the next slide, again, it mirrors the mobile crisis information. The highest number, of course, are the kids who have significant suicidal ideation, self-injurious behavior, kids who are really struggling, followed next by, some behavioral dysregulation, outward aggression type of experiences, and then you go obviously depression and anxiety. So we really talk about the whole kit and caboodle of kids suffering, right? We know our kids are still suffering. I think all of our marketing efforts and our shared language is, while there's no wrong door, we'd rather you come to the UCC's door and let us manage you. And if we can't, we have really good partnerships with the local emergency rooms to have a warm handoff to get you there. And our numbers for that, I don't even think we have them here, but our numbers for ED transfers roughly are around 3%. So if you look at our almost 1,500 kids, it's a very small number that actually need a higher level of care. And we track those. We are able to talk to CCMC and say, where do they end up? And for the most part, they end up in inpatient. So there's this, good quality assessments that are happening in the UCCs. So we're able to really meet the needs. Flip my page. So the next, obviously, 2 data points are important. Well, that goes to the 95.7% of the kids, keeping them in the community, right? The idea is that kids don't sleep at the UCC. There's no beds in the UCC for that purpose. When they come here, we're going to wrap them. We are going to create really creative safety planning. We're not going to treat these kids and families in a silo. With the appropriate releases, we're going to make sure that those next level of care providers have our information. We're going to do that aftercare work. We're going to call the families. We're going to make sure that connect to care has happened to ensure that they stay in the community. Or if they need a reboot, come back to our program. We have, I guess, frequent flyers. We have kids that have had multiple experiences at the UCCs. And again, we'd rather them come to us and reboot them than have them have to go to the emergency room to get rebooted. The second number I think is a really important number. Would you have gone to the emergency room if we didn't exist? And that's a question that we ask all of our families across the board in the UCCs. It's literally the question. If we didn't exist, would you have gone to the ED? And it spans between 48 and 52% on any given day. That's the number. And that number is really, really important. Number one, we were created to be an ED diversion, right? Get the kids in the right door. And I think we're meeting that need. The second thing is, I think if you flip that number, for me, when we were first creating the UCC, I was actually asking families if they didn't go to the emergency room and we didn't exist, where would they have gone, right? That was a really important narrative for us to understand. And many of the families, which I was very, very surprised at, said to me that they didn't think they can go to an emergency room for a behavioral health crisis, which meant, what did they do? right? And these were families sitting in their crisis, not having a phone a friend or their pediatrician or the ED. And yet now they have a place to come to. So I really feel like when we look at data, we have to look at both sides of the coin. I think the next couple of slides are just really focused on our goals and improvement coming to the UCC by race and ethnicity. I think you see across the board that they're all very, very similar, regardless of what race or ethnicity you are. I know I'm breezing through, but I realize I'm talking a lot. So we'll just jump to the referrals from UCC to other services. So I think when we look at what we connect them to, that's really helpful because you see a whole variety of services, right? You have your most intensive, right? Your PHPs, your IOPs, or even your inpatients, right? And you have your lower levels, which could just be outpatient level of care. And I think that goes to the span of families that are utilizing the UCCs, right? We serve kids 0 to 18. When we first created the UCCs, we thought that we were creating the highest level, right? Kids who really more so might have needed an emergency room. What we've very much became aware of is the definition of crisis. People's version of crisis varies, right? So we had a 3-year-old, 2.5-year-old come with her mom, and it surprised the heck out of us when we had a just walking child come into the UCC. And it turned out things that she was struggling with, her pediatrician could have helped her, a friend could have helped her, aunt could have helped her, but she didn't know where to go. And, that was a remarkable opportunity to help her. Again, her version of crisis and mine did not mirror, but we were able to support and ultimately get her involved in some lower level child services. So that's just an example of sort of the different levels of experiences when families come. So I think this data shows then where they go based on those different levels. Pass it off to Erin.
The closer. So of all the successes, the challenges to keep us going, we continue to experience a workforce shortage. So continuing to maintain staffing is challenging. Connect to care, we're constantly experiencing extensive wait list for the referrals that we're trying to get kids and families into, and barriers in that sense. That's very challenging to keep families motivated, and that sometimes is a reason for the frequent flyer status because they're not able to heal because of access to ongoing services that will help them. Just the time to embed ourselves in the system. I mean, I'll repeat it again. We really need time for the system to really understand who we are and to embed ourselves in the system in the same way that walk-in medical clinics needed time to embed themselves in with the emergency departments as well. The reimbursement rate, I think that's our biggest risk to success. The reimbursement rates at this point are too low to be sustainable. Our CEOs talk about the need for firehouse staffing, as I had mentioned before. The utilization trends are up and down. So we'll have days where we'll have 1 or 2 kids, and then we'll have days that there's 7, 9. I think that you guys had 21. What was your highest number?
Our highest is 10 in a day.
In a day, yeah. And our highest in a day, I think, was 7. And so those days were really busy, but then there's other days that we don't have any, but we still need to have the staffing there so that we're available for when the families are in crisis. If we were 100% funded through reimbursement rates and we had no kids there, we would be in the red all the time. So we really need sustainable grant funding in order for us to be sustainable long-term. And that firehouse staffing model makes a lot of sense to us and our leaders. I think we need the time to build that trust, and to continue the marketing efforts. But I think the biggest risk to our sustainability is obviously funding.
We will open it to questions now. I'd like to thank you for your presentation. It was really wonderful to hear. It was so exciting when the UCCs opened. I remember being at the one at the Village, and just to hear where we are now, it's really heartening. And as a couple of things, first, I wanted to let you know I was driving behind a bus yesterday, and it had the UCC. I took a picture because we're at a stoplight, and I saw it on the back of the bus. And I says, literally trying all different avenues to reach the public is what it shows that you're doing. And hearing all the things that you're saying today reinforces that. And I think really with the schools, I've noticed some correspondence I've had with different people in the mental health field. Sometimes at the end, when they say call 911 or 211, the UCCs aren't on there. So it's something that told me we still need to educate these providers, but clearly you're making a tremendous effort to do so. And I appreciate that. And you said something that was really interesting to me too, Amy, when you mentioned how some families, before we had something like this or not knowing about this, may see ED as a form of respite almost. And I think that is a point that's important to raise, because when parents are dealing with this and the whole family is in crisis, it is exhausting, and sometimes you don't know exactly what the avenue is. So I think that was really important to highlight. One of the things that I am curious about, because we're talking about four of these, and you're talking today about the community-based centers. I'm really also interested, not to put you on the spot, but about the hospital-based program. And then when we look at the map and it shows low level of episodes, but I can't help but wonder if that's because it's not, whether or not it's established in that New Haven area. So I'm speaking of the Yale program. Just wondering if you know anything about that in comparison to what we hear about the community-based programs.
I can chime in if you'd like. This is Jan Ponson, and I have to join you by video. And I'm in a hospital-based setting, so I'm off video right now. Apologize for any background noise. I think
Okay.
we've been. Can you hear me? Okay. Okay. Yeah. We've been operating and moving the process along with the UCC in terms of the design, the development, and also the training of staff to deliver care differently. And for September, we had 91 episodes of care. So for our last data, and as others have mentioned, October starts to spike, so October figures will be higher. But we consider ourselves operational.
Thank you so much. I couldn't tell if you were finished or not. I'm sorry for the delay. I'm curious though, when looking at for instance, the one in the Village, I remember in touring that, and it is an environment that feels very different from a hospital environment. And so Jan, could you speak to how it physically looks to go into the hospital-based versus what we see in the community-based setting?
The difference is, so this is where the design is important. So one of the challenges in the delay in the new space is having to move 5 other services to create the space. So this space will be adjacent to the pediatric emergency, but will be family friendly. So there's lots of light, lots of windows. So it's a space selected because there's lots of lights, lots of windows, and the space will be ligature free, which is different than some of the community UCCs, or the degree of ligature free will be different. But we're partnering with a firm that specializes in creating family-friendly environments, despite also meeting those needs. So that is where we are with the planning. But much of it is delivered with some modifications in an ED setting. Although there's space set aside for kids with behavioral health needs that are cohorted together. We have folks coming and delivering services in the ED, mental health counselors, and other, aside from the usual social worker, psychiatry, we have other elements of care that we provide within the emergency room setting that are different than in the past.
And thank you for that. And do you have a sense of timing around when that is to be completed?
The services are going to be all moved out by the end of December. So the last service should have moved out by the end of December, January, and then ground is breaking right after that. And I don't have exact timeline after that point. But somewhere between January and March is ground is breaking.
Okay, thank you for that. And I'd love to see if we can get a timeline on completion for that.
Yeah, I can get that to you.
Okay, thank you very much. So I think that's really important. I think one of the things that seeing the hospital environment, even at when we go to Connecticut Children's, versus seeing what this environment looks like, it's incredibly different. And I do think it's a wonderful alternative. But as you say, the marketing and as much as you're doing, we just have to continue to be patient and push that out. But I really believe that people who experience that, they're going to be great ambassadors to that as well. But thank you for that presentation. See if anyone else has any questions.
Yeah. Unfortunately, just one sec, Mickey. We have 1, 2, 3 plus me and Dr. Skronsky. We have 4, and we're already out of time. So I don't know how we're going to fit everybody in and stay on schedule, but we're going to try real fast. So here's my question. When you are going to all of the referents, have you spoken to all the hospitals? Do they know? Because I look at this and this mapping, and it's wonderful that West Hartford and Bloomfield and Hartford and Waterbury and Groton and New London are all utilizing, but we have a huge amount of the state which is not utilizing these services. So that's a significant concern, because and it's far to go, but when your child's in crisis, and when I spoke recently to a group in Stanford, they didn't even have any idea what the UCCs were. They'd never heard about them. And that was part of a whole child behavioral health group. So I just have some concerns. I really appreciate the work you're doing. And then one other question, and I'll stop. On the school referrals, does that include the school-based health centers? And are they primary, or is it administration who are calling? Do you know? It's okay if you don't know. I just thought I'd ask the question.
I actually didn't understand the question. Can you say the question again?
So on your reference, schools are the most.
Yep.
Does that include the school-based health centers? And if it does, what percentage of the school reference would be the health centers, since they are kind of the first line of defense?
I mean, I can tell you from our experience that does include it, but it doesn't break it out. So I actually can't tell you that data. If there is a school clinic that referred the child to us. There's, what also this doesn't tell you, and I know we don't have that much time, is we also get a lot of calls. So there's a lot of families or schools, many schools that will call and ask us to do like an assessment with them to say, is this an appropriate level of care? Sometimes they end up keeping the child because of their own in-house teams that can ultimately manage the child as well. But anyways, I don't know. We don't have that data to be able to answer that question unless you do.
We have 22 school-based health centers, so we get a lot of referrals from our school-based health centers, but we also get a lot of referrals from school teams as well, and the administrative teams as well. But to Amy's point, it's not a question that we break out. It's something we could add if you think that would be helpful data to be able to distinguish. We can certainly add that. With regards to your hospital question, we're constantly trying to add that. To Amy's point, there's a bandwidth challenge with the marketing, but absolutely, we are trying to get that. And I hope that you'll pass this video around too when you have it on your link and send it out. But we would be happy to go out to any of your contacts and do presentations. Our team is happy to do that.
Thank you so much.
Thank you.
Claudio.
Thank you. And thanks to both of you for coming. And I look forward to that video once we get a chance to see it. So in the interest of time, I'll sort of put some questions on the table and maybe we can do some follow-up and get your feedback in writing, unless you have some initial impressions. I really want to focus in on sustainability. I think that's a priority here. We stood up the UCCs. There's certainly a concerted effort and interest among all parties to make sure that continues to exist as an option in our continuum. And you mentioned something that reminded me of what Lori Seichel said when she came here and presented to us, and that is essentially that sustainability has two components. It's rates plus volume. And I'm hearing you guys say we haven't hit those volume targets yet. So first question is sort of in the highest and best optimal delivery of a UCC service, what numbers, what caseload numbers should you be hitting, and in what increment of time if possible? Secondly, building off of that, it would be very helpful for us if you had data not just on how many people you saw, but what hours of the day. I noticed that a lot of your schools are the referrals. The school time hours tend to be during the daytime. So looking at how important it is for that 24/7, or is there a different sweet spot short of that that's more practical and a right-sized approach? And then if you could provide, by way of follow-up, the breakdown of Medicaid, individuals that are on Medicaid versus commercial insurance, and what is the status of bundled payments with insurance as compared to, we know what the Medicaid rate is and the interim rate, but if you could provide some of the commercial information, even in aggregate, that would be helpful. So thank you.
Senator Seminara.
Thank you, and thank you for your presentation. I'll just leave you with some questions again. If they need to be answered at a later time, that's perfectly fine. You mentioned that in your Connect to Care that you're referring, and when you're referring, you're being faced with long wait lists. So where are you referring to? And if you're not able to get a referral done in a timely manner, what is happening to that person? Are you assuming that level of care, or is that person left floating in the community on their own? So those are two questions. And then one other one, you mentioned that you have staffing issues, and that is, I was wondering, do you have that currently, and how often do you have turnover in your places? Thank you.
I'm sure we're capturing all these questions. We are. Okay, thank you. Going around the circle, Mickey.
Hi, thanks. That was great. So a couple of things. The length of stay, how long are kids staying in the urgent care? And again, getting back to the Connect to Care, what kind of data is being collected around that so that we know it isn't going to turn into the emergency room situation where I don't know if you have kids that are staying there for 50 days, or I'm exaggerating obviously, but if they can't connect to care, then we need to know exactly where what is needed, and that kind of stuff. Okay. And then the other issue that I think is really important is that somebody mentioned the bus, right? And are you getting any state assistance for your marketing? You said marketing's really important, but it seems to me that it would be really important. That's very expensive stuff, video development and stuff. So it might be something to contemplate getting some assistance from the state to help with marketing. Oh, the last one, I'm sorry. It was the referrals that was mentioned before, that there were referrals to mobile crisis. I'm assuming that's after so is mobile crisis then serving as kind of a stopgap? Yeah, bridge. Yeah.
Thank you. Dr. Spronski. Sorry.
Hi, thanks. Quick question, and I think it's to Kelly. With regard to the mobile crisis utilization, you talked about cohorts coming from the community, family, and from schools. Is there a way of drilling down to understand or look at the profile of the kids that are coming from each of those buckets so that we can better understand the needs of kids who are coming from our schools and understand the population needs of those kids? Is that data available at some later date, or anybody?
Yeah,
No.
so I think that we do tend to look at, okay, what are the presenting problems when you're coming from schools versus self-family? We tend to see a little bit more disruptive behavior. So I think that general breakdown is things that we do and can certainly provide in more detail.
I just think it'll inform our conversation about school-based mental health, about what the population needs are of those kids that are getting referred to mobile crisis and then to the ED. And I just have one more comment. 3 years ago, I was on the work group that was initially discussing the creation of urgent care centers. And I just want to say, This is great news and congratulations because to take this from a concept and actually demonstrate that it's working and it's impacting the families and kids that it was intended. Um, Congratulations to you.
We don't, Commissioner, for you, we do.
Thank you. I'll make it brief. I've been to the New London facility. Just want to also say congratulations because it really is amazing. My brief question was just if you collect any numbers on whether any referrals are coming from school-based health centers at all, and if there's mental health capacity within those school-based health centers if a referral comes from one.
Okay, Javid, and then we'll do Vin Russo.
Thanks so much. Can everyone hear me okay? So gratitude times infinity to colleagues and agencies for taking this up, despite the clear lack of sustainable funding and the many risks that they had to take operationally. My question is about race and ethnicity data are we capturing race and ethnicity data? Are we capturing data by zip code? Because one of the things that I've heard from national colleagues where urgent care centers have been implemented is that at times disparities in access actually persist where people who have greater psychosocial complexity might be racialized, a higher degree of DCF custody, still end up in emergency departments instead of urgent care centers. So just a question for tracking.
And Vin.
No question. I just wanted to say thank you very much to our providers. We have some wonderful community folks in our state, and we're so fortunate to have them. And so all of us at DCF just appreciate the partnership that we have and how this idea from several years ago became a real place for kids to get help. And that's an amazing thing. So thank you all.
Thank you so much. And yes, we did catalog all those questions, and we will be circling back with the presenters to make sure to follow up with the responses. Our next data spotlight is from Caroline, and I'd like to give the floor to Carrie and Jackie. Thank you.
Hi, good afternoon. First, thank you to the tri-chairs and to the committee for having us. We're really excited to be here to present. I want to echo the comments congratulating the UCCs. It was a wonderful presentation and they are doing wonderful work. So it was great to hear that overview. So I am Carrie Borden. I'm the CEO of the Connecticut Behavioral Health Partnership at Carillon Behavioral Health. And I'm here with my colleague, Jackie, if you want to.
Good afternoon. My name is Jackie Cook. I'm a regional network manager with Carillon Behavioral Health.
So we are here to review some data on emergency department utilization, inpatient psych utilization, and then PRTF utilization. And I think those are three important levels of care when we think about the great work that's being done in mobile crisis and the urgent care centers to really look at this whole acute continuum. I know we reviewed a lot of data today, so we're going to try and keep it high level. We're happy to answer any questions that folks have or provide more detailed specifics if there's detailed questions. Okay, go to the next slide. So just for context, as a reminder, I'm just going to do a quick overview of the Connecticut Behavioral Health Partnership. So the partnership, the CTBHP as we call it, is a partnership between the Department of Social Services, the Department of Children and Families, and the Department of Mental Health and Addiction Services, who have come together to build this partnership related to Medicaid, Husky Health individuals, really with the goal of improving quality and access for Husky Health recipients in Connecticut. Carillon is the administrative service organization for the CTBHP. We've played that role since the inception of the partnership, since 2006. So I raise that because it's important for this presentation to keep in mind this is specific for Husky Health youth. I know the data we just saw was all youth across different payers. The information we're going to be reviewing today is specific to youth who have Husky Health, mostly data points related to ages 3 to 17. Next slide. Okay, so we'll start with some emergency department utilization. This is going to be information that's based on claims data submitted by the emergency departments when a child goes there for a behavioral health need. In this graph, the blue line is the total ED visits, and then the green line is ED utilizers. So we have some kids who go to the emergency department more than once in a quarter, which is why you're going to see that the green line is lower than the blue line. Overall, over the past few years, ED utilization has been relatively stable for behavioral health. We did see this drop, similar to what Aaron referenced, or actually when I was talking about mobile crisis utilization before, we did see this drop where there was a drop during COVID, and then it started to increase a bit, but has not returned to pre-COVID levels. And we do also see the similar utilization pattern where there's dips in the summer. We'll see, this is based on a calendar year, so in Q3, we tend to see lower utilization of the ED. I know one of the questions that the committee has asked about is, have the UCCs impacted the volume going to the emergency department? And I think we have seen, like in the most recent quarter, there was a slight dip. I think it's just early on to draw conclusions based on this data, and that we'll just continue to monitor it. I'm going to turn it over here now to Jackie to talk about what happens when youth get stuck in the emergency department.
So before we talk about the visualizations that we're looking at, I really quickly want to start with a definition about what it means when a child is quote unquote stuck in the ED. So a child is considered stuck in an emergency department when they have been there for 8 or more hours following medical clearance, psychiatric evaluation, and they are waiting disposition to their next recommended service. So in other words, they've been medically cleared, they've been evaluated, we know where they need to go, and they've been waiting to leave for 8 hours because that service is not readily available. Another important note is that that definition has changed. It changed in April 2023, so during the time frame you are viewing. And the old definition, what used to be 8 or more hours post-medical clearance, that clock would start, quote unquote, the clock would start. The reason for the change is that we feel this updated definition does a better job capturing the challenge with system throughput. And what I mean by that is the youth is ready to go. They've been evaluated, they've been cleared, they know where they need to go, but they just can't because of system throughput challenges. The old definition may have taken into account things like internal ED operations. How long does it take a psychiatrist to evaluate the youth once medically cleared? So if there is any differences in the variation or the volume that you're looking at, please note that the definition has changed and thus different youth are being captured for that reason. So what are we looking at? From the beginning of 2022 through Q3 2024, that's end of September of this year, that first visualization is showing you ED stuck volume. That top blue line is the total volume of youth that were considered stuck in an emergency department by the definitions we just described. And then we can also see the recommended level of care for which they were stuck waiting. That green is showing us they were recommended an inpatient psychiatric level of care. Gray is they were recommended a psychiatric residential treatment facility. For context, a PRTF, psychiatric residential treatment facility, is considered a subacute level of care. What I mean by that, it's 24/7, it's a fully staffed setting, it is not a secured facility, it's not a hospital facility, but it does provide very intensive psychiatric care to children and adolescents in a very highly structured setting. So not quite as intensive as a hospital, but still staffed 24/7. The orange is recommended SFIT. So SFIT is a short-term family intervention facility. Those facilities closed in March of 2022. However, because that time frame is still captured on this historical data, it is a field that we are still displaying. And finally, the last field is recommended any other level of care. So this would be youth stuck in an ED waiting any other aftercare service that I didn't just previously describe. The second line graph below illustrates for us the volume by the actual level of care to which they ultimately left for. Most commonly, we can see that youth typically are discharged to the quote unquote other level of care. So this would be non-inpatient, PRTF, or SFIT. The second most common being youth admitted to an inpatient psychiatric facility. Go ahead. to the next slide. So that previous slide showed us volume. This is breaking it down a little bit further. We're looking at average length of quote unquote stuck stay and volume as categorized by youth with and without DCF involvement. What we're looking at on the top visualization is that average length of stay, and on the bottom, the total volume. Green represents youth with DCF involvement, gray represents their youth without DCF involvement, and blue is that total. I think the biggest difference to note here is that while DCF involved youth have a much lower volume than their non-DCF involved peers, on average, their length of stuck stay is on par and oftentimes much higher than non-DCF involved youth. Go ahead and go to the next slide. And subsequently, this shows us what we refer to as a frequency distribution by the ranges of time youth spend in an ED. So on the left, we're looking at all youth. The middle is DCF involved youth, and then non-DCF youth. The biggest takeaway here is that regardless of DCF involvement, most youth spend between 3 days or less stuck in an ED. That said, as you can see, there are not a small number of youth that do spend longer. Go ahead to the next slide. So here we have some Connect to Care data. We were talking a lot about that with the UCCs in the previous presentation. This is showing us related information for youth that are connecting to care, both within 7 days of a behavioral health ED visit and within 30 days of a behavioral health ED visit. That green line represents the percentage of emergency department visits that connected to care within 30 days of a visit. And the blue line is within 7 days of an emergency department visit. If we look at the beginning of the time frame, Q1 21, we can see that about 57.5% connected within 7 days, about 70% within 30. And then if we go all the way through Q2 24, which is the most recent full capture of this claims-based data, those numbers are somewhat lower. While it does look stable over time, that difference does tell us somewhat of a decrease since the beginning of 2021. And one thing I do want to mention before we move on is I know many of our provider network are on the call here today. This is something, in spite of system throughput challenges, they do a great job with. The numbers don't tell the whole story. This is in spite of workforce challenges, wait lists for outpatient and home services. These numbers don't tell us the number of calls that they make to families to connect them to the care after the case, the number of referrals that are put in, bridging efforts that are made to ensure youth and families make it to that next level of care. Go ahead to the next slide. And related, what we're looking at here is return visit volume. So while the previous slide showed us connecting to care after an ED, this information is showing us youth that return back to the ED, both within 7, that blue line, and within 30 days of a behavioral health ED visit. Over time, again, similar to the trend line from the previous visualization, somewhat stable over time, peaks and valleys, depending on things like seasonal spikes, high volume timeframes, but overall, somewhat stable. Go ahead to the next slide. So now we're going to transition away from the emergency department to talk a little bit about data for youth psychiatric inpatient facilities. So very quickly, the facilities that are making up the data that we're looking at on this slide, there are 7 hospitals whose data we capture here. This is Yale New Haven Hospital, St. Vincent's Medical Center, Manchester Hospital, St. Francis, Hartford Hospital's Institute of Living, Natchog Hospital, and Four Winds Hospital in Katona, New York, that does accept a lot of Connecticut youth for treatment. Not included in this data is Solnit Hospital, which is the state hospital for children and adolescents in Connecticut, and we'll look at their data in just a bit. So similar to the previous ED Connect to Care data, it's the same methodology. These are youth connecting to their next recommended level of care following an inpatient hospitalization within 7 days and within 30 days of discharge. We can see over time, this metric has somewhat decreased while the trend line is relatively stable from the beginning of 2020, which it's hard to think back that far, but was considered pre-COVID, to the time frame we're looking at, which is through June of this year, somewhat of a decrease in time. And similarly, what we're looking at here is Connect to Care data, but this time exclusively for Solnet Hospital. We can see that there is a lot of differences quarter to quarter for Solnet. One thing to keep in mind is that the N sizes or the volume of youth that are discharged from Solnet compared to those 7 community hospitals mentioned before is much smaller. So those percentages may look a little more dramatic as a result. One thing I should have mentioned before, but particularly becomes relevant with Solnet because of the frequency to which they discharge to these services. If a youth is discharged to a non-billable, so a service that doesn't accept Medicaid, that will not be captured in this data as we collect it based on that first claim or authorization that is submitted following either a discharge from an inpatient hospital or following an emergency department visit. Go ahead to the next slide. And finally, we're going to talk a little bit about the psychiatric residential treatment facilities, which you'll hear me refer to more commonly as the PRTFs, because that is a mouthful. So what we're looking at here is a little bit different than the data sets that we reviewed previously. So this is what we call our awaiting services data. So these are youth that are what we call on overstay in a PRTF. So they have met their clinical goals. They're ready to discharge. However, similar to the ED stuck youth, that next level of care can't take them yet. So they are stuck sitting in the PRTF, ready to go, but can't quite discharge yet. What we're looking at is calendar year 2023, and I'm going to take you from top to bottom. So the top shows us the 5 psychiatric residential treatment facilities in the state of Connecticut. There are 2 state facilities, Solnet North, which treats adolescent males, Solnet South, adolescent females, and then the community PRTF, Boys and Girls Village, Children's Center of Hamden, and the Village for Families and Children. You can see their overall total discharge volume, and then the number of discharges comparatively that were spent awaiting services, the percentage that those discharges make up, and then the total days those discharges spent waiting, and then an average. The table below shows us the levels of care that the youth were stuck awaiting. So we have therapeutic foster care, for example, residential treatment centers, educational programming challenges, and so on and so forth. We can see the volume of discharges that were awaiting every particular service, the percentage, the total, and the average day spent waiting. We can see demographic information illustrated to the right. Overall, the demographics for youth awaiting services from a PRTF in 2023 is consistent with the overall volume of youth that were seeking treatment from a PRTF. The only difference being the DCF youth are an overrepresentation in this data set. For example, in 2023, they were only about 30% of the overall youth being treated in a PRTF, yet you can see here they make up just under 50% of the youth experiencing an overstay. Go ahead to the next slide. And what we're looking at here is calendar year 2024 to date. So 2023 was shared to be able to provide some context and comparison. Keep in mind, this is not a full capture of 2024. We're not done with the year yet. Claims are still coming in. Authorizations are still being processed. These same 5 providers, the same associated methodology. And once again, the demographic information is overall in line with the volume and presentation of youth seeking treatment. However, we do see DCF being overrepresented. Again, they were about only 27% of youth seeking PRTF treatment, yet make up 50% of the discharges that are stuck awaiting services. And with that, we'll pause for questions.
So I recognize that was a lot of data for different levels of care. So we're happy to answer any questions. I think it speaks to, some of the strengths in the system as we look at throughput as well as where there are some challenges. So happy to take any questions.
So I'll just kick off. I have one question, and I'm not sure it's even an accurate question. On the page, youth ages 3 to 7 behavioral health return visits, and then prior to that, the Connect to Care. I was just looking at, you've got the Connect to Care, and then you've got the return. And I was just wondering if the length of, and I don't know if you can even give me an answer, if the degree of Connect return visits were related to the length of time it took to connect to care.
I think it's a great question, meaning is there a relationship between how timely someone connects and whether they readmit? We
Right.
don't have that specifically here. It's something that we could bring back as a question. I think it's a great question.
Okay, thank you. Anyone else? Oh, okay. Christina.
Thank you. Thank you for the presentation and the information. It's very helpful. One of the things that we see sometimes is kids who are in the emergency room or, you know, in the emergency room and recommended for inpatient, right, or a higher level of care, and the recommendation changes over time while they're sitting in the emergency room because their presentation changes. And I wonder to what extent the data captures those changes in recommendations. And I sort of have that question with regard to the ED stuck, but even the sort of psychiatric residential treatment facility, the discharge, there's sort of kids waiting for group homes. And does the data capture at all changes from sort of an initial recommendation for inpatient or group home to something that's a lower level of care, not because, primarily because we could not get that and things change over time?
It's a great question. Does it follow the story of the youth, basically? It is based on the last reason. So the data will capture what is the final either disposition or reason that they're awaiting.
Michael.
Thank you. You guys are data geeks, and that makes my heart happy. I have two questions. The first one has to do with the return visits in the EDs. And if you don't have this now, but could report back to us, I think it'll be really helpful to us in the task force recommendations. And that is, do you break out by neurodevelopmental disorder, intellectual disability, or ASD on the return visit question? Because I have a certain experience with that, and it seems that it might possibly be different. And if we're talking about what we need to make as recommendations, that could be really helpful data from you guys. The second one has to do with the PRTFs and length of stay with the same question. Folks with neurodevelopmental disorders and what their length of stay would be as compared to others, because that would have workforce implications as well as workforce competency implications. Knowing that workforce recruitment is hard and retention is harder for that particular group. So those are the two things that you can comment now. You can send something later to all of us, but whatever makes most sense to you.
Well, first, we love being good company with data geeks. As you said, we have access to that information. It's not readily in this dashboard, but we can bring it back as questions. I will say anecdotally, when we look at youth who are stuck in the emergency department and some of those who are on that frequency distribution more on the right side, anecdotally, we do hear more about youth with ASD or IDD staying a bit longer, but we can definitely bring that back.
The other part of that question is the 30-day returns. Okay, so if you could factor that into there too, because my experience with my patients that go in, it's not their only first rodeo.
Okay.
Okay.
We'll bring that back.
Howard.
Yeah, hi, Carrie.
Excuse me, I'm sorry. And then Representative Walker, we know you're there. We're coming.
I'll be quick. Mine, mostly a comment and a challenge. I think we all know that this is great data, but it's only a snapshot of and part of the picture. And as we know with the ED, it only represents a portion of the kids that come into our ED. And the question is, how do we capture similar data for that cohort of kids that are commercially insured or uninsured who are still accessing care and need care? I know that the Connecticut Hospital Association has been collecting daily data on ED utilization that does capture the whole entire population. And I'm wondering, is there a mechanism for us to capture that data and marry it with some of this data so that we can get a more comprehensive look at the total population of kids that are in need of emergency care? Thanks.
I think it's a great point and a great question for the council. You are right that under our purview, we only have access to Medicaid information, but I think it's a great point.
Thank you. Rep Walker.
Thank you, and thank you all for your the data that you presented to us. I have a couple of quick questions about the data, though. The time frames are different in almost every other slide. In January 2019 to June 2024, and then you go to the next page, it's June 2022 to September 24. And then as you go through, each one has got a varying degree, so it's hard to compare any of the information to sort of see the trends with the population. And the other question I had, I wasn't quite sure what you meant by it. It said that it was data that was captured by DCF, and I was kind of confused. So the data that was captured by DCF is different than your data? It should be the same, shouldn't it? Because you're contracted by DCF and DSS to work with this population, isn't that true?
That is correct. So in terms of the time frames, you're right that there are different time frames based on the measure. Some of that is based on the dashboards that we have and how much historical data is. So we apologize if it's confusing. There are dashboards, for example, like the ED Stuck dashboard is based on self-report from the hospitals. So we can have more timely data on that because that's in real time. For things that are based on claims, providers have up to a year to bill. So we have to build in a lag to allow providers to bill and the data to, as we say, cook enough that it's complete. So we wanted to bring as most recent data that we had, but there are some, specific things related to methodology. In terms
You guys, and in terms of the DCF versus your data, that threw me for a little bit.
I'm trying to remember at what point that
It says average length of stay and volume over time by DCF status. And so I'm trying to understand why wouldn't all of this be DCF status because that you are contracted through DCF to provide this data to us, correct?
So the data that we're looking at is for Husky Health youth. So we're looking at of all youth who have Medicaid, and then we're breaking out for DCF versus non-DCF because not all Husky youth have DCF involvement.
Right.
It's actually a small percentage.
Okay. All right. So the difference in that regard is just those that are just DCF. Okay. And then the other thing that I thought was interesting was that you do ages 3 to 17, and then you change that. Was that because of access to the actual data or historical data that you were using? You have on SolNet, you have ages 6 to 17, but then in the beginning you have 3 to 17. So is it by the definition of the population that you're looking at that DCF is involved with, or is it just because you didn't have that information for the younger youth that might have been detained or interacting with DCF at that time? Is that?
So it's a great question. The age difference is actually independent from DCF. It's related to the level of care we're looking at and who can access that service.
Okay.
So for example, a 3-year-old would not be eligible for PRTF level of care, for example, so we would not include that in the PRTF.
All right. Thank you, Madam Chair. Thank you. Thank you, everyone.
Anyone? Christina?
Can I just ask you to clarify in terms of the DCF status? Do you mean any DCF involvement or kids who are committed to DCF?
Any DCF status.
Any DCF
So it
status.
could include investigation, for example.
So it could
Yes.
open investigation
Yes.
or child under protective
Yep.
supervision. Okay, thank you.
Okay, thank you so much, Carrie, and thank you, Jackie. We very much appreciate you being here and sharing your information.
Thank you.
Sorry, I believe you have one more question. I don't know if you want to take that. It's on Zoom. Sorry, on Zoom. Alice? Sorry.
Thanks. I'm sorry. I just wanted to clarify the data. It was a little hard to read on my screen. I apologize. Are there kids who stay in a PRTF over 600 days?
So it's not impossible. It's incredibly infrequent, and trying to recall a particular discharge that had a length of stay in my tenure.
Yeah, I saw that it says days awaiting was like 600 days. Is that one child or is that everybody waiting for all those days?
That's cumulative across all of the youth who were awaiting their total days waiting. So that would not be
Okay.
for a child.
Thank you.
Absolutely.
Thank you so much. And to our presenters, and we will follow up with you all. Oh, sorry, one more. Sorry, Vinny. Okay, sorry.
Not a question, but again, I just want to say thank you to the Carillon team for all their support for our kids, our families, and for the department. We really appreciate the partnership. So thank you.
Thank you. I appreciate that.
Okay, just looking around the room one more time. We're good? All right. Thank you, everybody. Thank you to our presenters, and we will follow up with our presenters from today and circle back with that list of questions back to this committee. The next item on the agenda is more of a sort of an administrative item on the agenda, and this has to do with, I want to turn back time a little bit till October. In October, we delivered to this committee a set of draft recommendations that are being that were developed through the two work groups that you currently have, and that is the infrastructure work group as well as the services work group. The infrastructure work group is is chaired by Alice and Jason, and then the services work group is chaired by Edith and Jan. And they spent throughout the months of the summer meeting and identifying priorities and identifying recommendations to come to you. Those drafts are still in progress. So like I said, they are in it's a draft. And so what we are looking for is feedback from this committee, from your membership, feedback on those recommendations. We collect all of that feedback, we bring it back. I just want to describe a little bit of the process. Collect all that feedback, bring it back to your work group chairs, must continue to catalog all the feedback. And with the chairs of this committee, along with the work group chairs, we review all that feedback and make adjustments as appropriate. The goal is to bring back a set of revised recommendations that have consensus amongst the groups, and for you all to be prepared to vote in January. And so part of our next step is that in this month of November, as I said, we're collecting your feedback. Please send that either to myself or to Emily, our new staff, or you can also reach out to your work group chairs or to your TCB chairs to provide your feedback on any of those recommendations. While that feedback is being collected, we at Tau Youth Justice Institute are also working with your work group chairs in developing a report. That report will provide some data like today or some summarizations of different studies that have been released, like for example, the Medicaid DSS study, or for example, a workforce study. So there will be some references or some data to some of what Claudio had mentioned last month around, justification for, or what do we know about? What does the data say? What does the research say? What does best practices say? What does it look like nationally, and what does it look like in Connecticut? And I'm sure there's several other questions there, but we will, my goal, I do not want to deliver to you a 100-page document because that's just not, that's quite a bit. But our goal is to provide to you a report that provides support for recommendations, shows some impact, and make it digestible, and a few fact sheets that you can all utilize, whether you are somebody who is a legislator or whether you are somebody who is an advocate for this work. So that is the process in which we are in right now. Our goal is also to prepare you and have you ready to vote in December to determine whether or not some of those recommendations will be moving forward to, for a legislative bill. And so with that, that is the status that we are currently in. I did want to give Alice Forrester, the Infrastructure Work Group Chair, an opportunity to present to you as the Infrastructure Work Group. There were some questions even last month about some of the data around one of the recommendations. And so wanted to do a little bit of level setting. And so we'll give the floor to Alice Forrester, the co-chair of the Infrastructure Work Group.
Great. Thank you so much, Erica. And I'm sorry I can't be there with you today. And thanks to both the infrastructure chair, co-chair Jason, and the folks on the services committee. We've been working actually pretty closely together, which has been a great experience. We actually have agreed upon one recommendation in general, which is to focus on I'm sorry, I'm just trying to pull up the right screen. Focus on the Medicaid study. Our recommendation is, can you see my screen?
Yes.
Okay, good. Is that we should immediately provide funding and policy changes needed to increase the Medicaid rates, behavioral health reimbursement rates to the average rate of the 5 comparison states as described in the recent Medicaid rate study, with inflation adjusted for the year implemented. So the rate study estimated this would cost about $42.4 million and $23. And we're looking at $24 being 45.5. And I know, that's an extraordinary amount of money. And, I know some folks aren't too thrilled with the state comparison data, but Medicare does not pay for behavioral health. And so it's very difficult to compare the children's Medicare children. You can't compare the rates for that. But it just to remind you that the study showed that we were about an average of 62% to the comparable states, and that, as I said, it would be about 45.5 million. And although some of the alternative payment methodology work of the CCB BC or some other work, Clifford Beers is actually piloting an alternative payment methodology for care coordination, are great and promising. But in general, we are in a place in the state right now that is really, really behind in terms of financing. And I just wanted to share some data. This is data from 3 agencies across the southeast southeast of Connecticut. So one in the Greenwich area, one in the middle of the state, and the other one in the Bridgeport area. So they're a little different. So I just want to explain. This is the data for a 45-minute session. So the therapy cost that it costs to deliver that session is about $200, $201 on this particular. This data is updated up till 2024. The Medicaid reimbursement for that $200 session, which includes supervision, documentation time, case management, anything else that it takes when you're seeing a child with mental health issues, the Medicaid rate pays $96.78. So there is a loss of 104. Now, I want to just show a little bit around the DCF grants that are only at the licensed outpatient clinics. Some of us have DCF grants. So again, the therapy cost for a 45-minute session would be 201. The reimbursement from Medicaid would be 96. The this is a somewhat escalated number, but about $53, $54 would come from the DCF grant, which is actually supposed to pay for all of the data that we're supposed to give. There's a whole scheme of things that the DCF grant is supposed to pay for that are not covered under Medicaid compliance, and that is, you know, the DCF compliance regs that we have to follow. And here we are then, those of us who are lucky enough to have the outpatient grant are only losing $50 a session. And of course, you know, there's tens of thousands of sessions delivered you know, in a year. So you can see that number just escalates extremely high. I'm going to show you, and this is the Clinic A's data in terms of the DCF and the collections from Medicaid. And the actual cost is in the yellow, 33,492,000. And you can see that the annual loss for an outpatient agency is about $1 million. And I did run this by a few of my colleagues. A lot of them don't have this data at hand. But this is pretty reasonable. The feedback I got is true. And you may say, well, how do you run a business where you're $1 million loss? Well, what you're doing, and you'll see in Clinic C, chasing grants, chasing other funding mechanisms, philanthropy, whatever you can do to make up the difference of the actual cost that it is for us to deliver to Medicaid patients. I just want you to know that I'm not presenting outpatient data from, outpatient data from private insurances, but in most cases, the private insurance is about somewhere around 60 to 80% below what Medicaid pays. This is Clinic B. Their average cost per session is $211. And their average insurance reimbursement is 93. And the DCF reimbursement is 49, and they have a funding gap of $69. Very similar in Clinic A and B. Now, this is Clinic C, which is not an enhanced care clinic, which means the $93 that you saw in the other two agencies is enhanced because we're supposed to then take every single person who calls and get them in within a short period of time, offer them a session. So this clinic is not an enhanced care clinic, nor is it a DCF funded clinic. And I really, if you look at this data, it's a little different than the other data is laid out. Their Medicaid reimbursement, that they're working on an hour session. The other two sessions were 45 minutes. So the Medicaid reimbursement for 1 hour is 105. And then they have to raise $111 in private fundraising, other grants to be able to deliver the service with a gap they experience of $25. So their cost per unit visit is $241. And then they included data, which I didn't want to complicate things too much today, is on the psychiatry, right? So the reimbursement per visit usually is 30 minutes, I think, is about 102 for a psychiatric visit. And then the total cost for half an hour is 195. And then they have to raise the difference of close to 90 or another $195 to be able to deliver the psychiatric services. So as you can see, the funding gap I would say the blue and the yellow is the funding gap, to be honest with you. I think that this agency is doing an enormous amount of work to support seeing fit, Medicaid folks, but I think the funding gap is really the difference between 111 and 120 and $24. So, you know, we're really talking about $140 funding gap in the clinical services for someone who's not an enhanced care clinic and who is not funded by DCF, underfunded by DCF. So I can, you have copies of that data. I just wanted to put it into reality for you. You know, it's not normal for many of us. I've been the CEO of Clifford Beers now for over 17 years. And when I first started, I always thought, oh, I must be doing something wrong. I must be doing something that other people aren't, you know, losing so much money. And to be really honest with you, about 5 or 10 years ago, I decided we did everything we possibly can. We went into electronic health records. We went into delivering services quickly, hiring front desk staff, working on the systems, doing lean processes to make sure that everybody is getting seen, increasing caseload, which we also during COVID had to increase salaries, you know, supervision, really, you know, moving towards a very efficient, high-level agency to be able to see the thousands of people who call for services. And honestly, this is the state's responsibility. The state has been underfunding us in behavioral health, and we have that documentation in the phase 1 study. And you know, it's at a place, it was coming to a head in right before COVID, and now is completely a problem because the ARPA dollars are gone. And here we are, you know, I have a cash flow analysis on a weekly basis, talking to our banks for a line of credit, and you know, am really, you know, we've done some layoffs in the last, and a lot of my colleagues have done layoffs in adult and children, of not clinical people, but of people, you know, whom we can't really do without, but we can't make payroll. So it's come to a point where I think we have to call it for the state. And there's absolutely unacceptable that the state pays 50% or more sometimes below what the actual cost of the service is. I'm done, Erica. Thank you.
Okay, thank you, Alice.
Hi, I have one quick question. This is Senator Seminar. I just want a point of clarity. Did you say that the private insurance is 60 to 80% lower than your Medicaid rates?
Yes. And to be honest with you, it's getting worse as we go forward. The contracting is becoming harder and harder with the private insurances, so much so that we're beginning to say, you know, we just can't, we can't take your insurance if that's, you know, if that's going to be the case.
Thank you so much.
Edith, online.
Yeah, thank you, Alice, for the presentation. You know, as a follow-up, just quickly, being a service provider in Bridgeport, I read this once that a legislator put in the paper that if the state were contracting with someone to have a road built, they would never tell the contractor, this is what we're willing to pay, and then you have to fundraise the rest. And when you stop and think about that in terms of service providers for the Medicaid population, that's genuinely how it feels. It puts the burden on the providers, and it is very difficult to sustain, to Alice's point. We've come close to closing down several times.
You have one more question, Tammy Freeberg, I believe.
Yes, hello, Tammy Fruberg from the Village for Families and Children. I'm sorry I couldn't be in person with you today. Um, I did want to say, I know that this question of whether Medicaid is the better payer or commercial is the better payer is an interesting one. And I know it's come up in a number of, like in different ways throughout our conversations. And I just wanted to acknowledge that this situation is largely true for community-based organizations like the Village and Clifford Beers. Um, uh, and not as true for our hospital-based health systems. So I think if you talk to some of our friends at Hartford Healthcare or Connecticut Children's, their Medicaid rates are actually lower than their commercial rates, which I think I don't know, speaks to a little bit of how the contracting leverage works with commercial payers, quite different. But community-based providers certainly do not have the contracting leverage that health systems do with payers. And so there's a little bit of a dichotomy. I think for health systems, Medicaid is the worst payer. And I think for community-based organizations, commercial payers are the worst payer. I just wanted to put that out there.
Thank you. And when Commissioner Gifford's team presented on the insurance presentation quite a few months ago now, there was clarity that the private insurance companies are looking at the Medicaid rates and are watching them very closely. And if they're low, then they feel empowered to then themselves be low.
And just a point of information for those families that have commercial insurance, many of them are facing very high deductibles, which really becomes the barrier to care. It's not necessarily having the insurance, but it's meeting those deductibles that those plans have established.
Right. And also, Doctor, you know that a lot of private providers do not take any insurance at all. And so a lot of the work, if you're going to a private provider, is really cash based because it's so difficult to collect and it takes so much staff to do that.
One last question.
Can I ask Alice or any of the other providers, can you speak to what the impact is on children and families of the rate problems that you're describing?
Sure, absolutely. We have only so many staff. And many children and families, I'm really coming at it from a children's perspective, want after school hours, but we can't offer them after school hours because we only have a certain amount. And so we're able, we're able to offer them, let's say, a Friday at 1 or a Friday or a Monday at 10 in the morning, and families don't, because they're working, because their kids are in school, they cannot make that a regular appointment. So a lot of them are holding off and waiting for an appointment that could be provided later in the evening. And so care is pushed off. So the reality is that they're not getting care when they need it and how they need it. And, the other important thing is that their care is not always solved. Their needs are not always solved in an individual therapy session, especially when you're working with children and families. And the work that it takes to be able to do case management, care coordination with the family, help the family address their basic needs, understand what their healthcare problems are, really takes an enormous amount of time that a lot of our clinicians, because they're being pressed to hire, hold a caseload, are not able to serve the families. And so the model of care is also, by it being underfunded, is not really the holistic care or the system of care we really want for our children and families that we've been talking about in this committee.
Quick question, follow-up, Alice. Thanks for your presentation. Just wanted to think through, because I think a lot of times rates have different components, and if you could help us unpack a couple different dimensions. So one is by specific code. I think it would be really helpful for us to, as the work group keeps reiterating on specific codes, it may be the case that a 45-minute visit is off by a certain increment, but a 1 hour visit or a different increment of time has a different variance. So it would be really important if we could sort of reconcile some of the feedback you have by code. The other thing I would say is I think there may be a difference, and I'm picking up on Howard's point somewhat here, where it's not just a matter of cost per unit, but also the access issues. And in particular, sometimes the way plans are designed may not cover certain behavioral health services. So I don't know if you or the work group members have any sense over coverage and plan design. I think that's different than parity, right? If it's covered by both, then it has to be there has to be some comparability to those services and the coverage, but it doesn't necessarily mean the plan design has to include all services. And I have sometimes found that Medicaid is broader in its inclusiveness of different types of services than certain commercial payers. And I don't know if you can help us understand that difference. So
I think Medicaid has, I'm sorry, Claudia, if you weren't finished. I
sorry,
think
Alex.
that Medicaid has done a really noble job of trying to make services available to folks who are on Medicaid. You know, one of the most recent, probably 6 or 7 years ago, Michael, I could be wrong, is, you know, increasing rates for testing for ASD or behavioral therapy or doing most recently the services were increased in this budget year about 3%. But in general, across the board, the services are coded really by time is the underlying factor, a little bit around what is delivered. So there is an intake that may not be exactly timed, but usually takes, with all the paperwork that has to happen, at least a good chunk of 2 hours. And so, almost every other service, I think, is timed. So you saw a little bit in the demonstration, like $93 for a 45-minute and maybe 105 for an hour. You know, that's the difference that happens. But in general, it's really it's pretty uniform. You know, the hourly or the minute rate, if you will, for behavioral health, and it runs consistently, significantly under what the true time, what the true cost is. In regards to plans, um, I I went into this business because of managed care, because we had to negotiate with 5 or 6 different managed care companies, and we weren't getting paid before we were in ASO. Now that we're in ASO, the coverage is very uniform, very acceptable. Working with Carolyn is you know, very easy when it comes to most of the normal codes. Where it gets problematic that I see with the commercial insurances is really around testing and you know, other specialized services that the family might need. They get less happy about approving those kinds of services. But I don't know if any of my colleagues would like to speak to that in a different way.
I'm just conscious of the time. It's 4
Sure.
o'clock. So, Michael, did you want to weigh in there?
Yes to the testing problem, and yes to the care coordination and management that goes on to wrap around the more impacted kids with neurodevelopmental disorders.
Case management is $15 for 15 minutes, I think, in Medicaid. Maybe it's a little different, but it's $1 a minute.
Yeah, definitely nothing. Alice, thank you. And Edith, thank you for your comments. And it's a real problem. Without a question, we can't afford to have providers going out of business when we're talking about the access to care. So it is something we are all going to have to figure out how to fix, and I don't have an answer straight up, clearly. I'll turn it over to you, to Erica.
Thank you so much. And thank you, everybody. Just very quick, I don't want to hold you anymore. Tomorrow, for those of you that registered, we are doing a virtual strategic planning session. Yes, we carved out a significant amount of time for you, but we are most likely not going to use all of that time, but we will start promptly at 9 o'clock. The goal tomorrow is, as you can see in the last slide in your handout, we won't project it right now, but the last slide of your handout is tomorrow we're going to, last month you identified purpose statements for various parts of the services or the work, and then and ranked. And then tomorrow we're going to identify or narrow down the strategies and who we would get information from and what specific information we would get from them. So more details to come for tomorrow's strategic planning session from 9, it's starting at 9 virtually. If you have not registered or if you need access to that link, please reach out to, actually, it's a rally for today. So, okay. Thank you, everybody. Oh, two things, changes. I think Senator Mar, you mentioned this before. We're changing our meeting times. So the TCB December meeting is scheduled for December 18th, 2 to 4 here. And then the January meeting, due to holiday and then the start of session, we changed it to January 15th, 2 to 4. Okay, thank you, everybody.